So today we'll be looking at the perioperative management of Jehovah's Witness patients undergoing cardiac surgery. The outline of what I'll be discussing today, I'll be looking at a case presentation that happened about 5 years ago, and just a little background on Jehovah's Witnesses and their principle with regard to blood transfusion, and what is the big issue in terms of, for us as a specialty for cardiac surgery, it's a little bit more riskier than other specialties, and then what our management is in terms of perioperative management. So the case that we'll be looking at today is a case of Mr. TB. He's a 75-year-old man, Jehovah's Witness. He was relatively well until about December 2018, when he had a non-ST elevated myocardial infarction, and he had acute rupture of his papillary muscle to his mitral valve. And essentially what that does, it causes a torrential backflow from the left ventricle into the left atrium and into the pulmonary vasculature, and it causes pulmonary edema. The patients tend to be extremely sick. So he was very sick at the time, and they had done angioplasty to the artery that was blocked, which was a circumflex artery, and had put in an emergency mitral clip, which was a temporizing measure to help to reduce the mitral regurgitation. Eventually, he'd want to need, when he's at a better state, surgery for the mitral valve. So that went okay. In July 2019, he had severe mitral valve regurgitation and he needed surgery. At the time, his blood count was 116 grams per liter. So in October 2019, he had his surgery. Before he had his surgery, there was an extensive pre-operative period where they did obtain consent for different factors of blood, the cryoprecipitate, albumin, and the use of the cell saver machine. And he went on to have his surgery. He had his valve plate, which were changed, and he had a bioprosthetic valve. And the surgery went as planned. There were no complications in the surgery. He was successfully transferred to the recovery room. And then shortly after, immediately after, his post-op HB was about 80 grams per liter. He was hemodynamically stable. At about 2100 hours, there was a cardiac arrest, and he was found to be in a large volume of pool. And there had been a dislodged line, and he was bleeding from it, and he had arrested. When they had done a blood count, his HB came back at 44 grams per liter. So he was resuscitated, and he's a Jehovah's Witness, and we had already known that he was not going to take any blood products in terms of pack cells and whatnot. His HB in the morning was 49 grams per liter. His blood pressure was 74/55. We had to go through various measures, emergency measures, to try to keep him, to sustain his hemodynamics. He was nursed head down. He was on high doses of vasoconstrictors. He was given iron, vitamin C, B12, folic acid, erythropoietin. He was kept sedated and ventilated. This is to try to maximize oxygenation. He was kept at about 35 degrees. He was on inotropic support dobutamine to help to increase his cardiac output, high FiO2, and try to minimize any blood sampling. And this is just a look at his blood count through his stay. So immediately after, the day after the incident, it was 44, then it went to 49. And then as the days go by, it slowly picked up. And on the 15th, we were able to extubate. And then by 17th of October, they were able to discharge. And as you can see, it slowly improved. Sorry. And we were able to discharge him a little less than a month with an HB of 93, and he's currently doing fine. So in terms of Jehovah's Witnesses, just a little background on the religion. It was founded in the 1870s. Currently, the membership is about 8.7 million persons. In terms of what is it with blood that they don't accept blood, it's actually thought to be related to the Bible and certain scriptures. And this is a direct quotation from their website, in that the Old and New Testaments clearly command that they abstain from blood. And it's thought to be blood. God views blood as represented life, and it's sacred. So they don't accept any blood in terms of whole blood or its component, in terms of red cells, white cells, platelets, or plasma. And once the blood leaves the body, it has to be discarded. In terms of them doing autologous donation before surgery, they don't do that. Once it's out of their circulation, they can't use it. So they started not accepting blood in 1945. Now, in terms of the different fractions of blood, like maybe albumin or what we call cell salvage, I'll go into a bit more detail about that in a few slides down. It's a personal choice, and it's somewhat of a gray area. Some persons will accept, and some persons won't. But before the surgery, in the preoperative period, there has to be a significant discussion, great discussion with the patient about what they're willing to do and what they're not willing to do. And then in the case of the patient, you do have a very small minority of patients who will accept blood. And in terms of what does happen to them, they tend to be expelled from their religion. And it can be quite devastating. In med school, I remember being told of a story of a patient who did take blood products, and then he was ostracized from his family, from his community, and he eventually committed suicide based on that. And there's another patient that I met. He was involved in a motorbike accident. And this is back home from Kingston, Jamaica. He was involved in a motorbike accident, and he had multiple rib fractures, had lost a significant volume of blood, and he needed to go for urgent surgery. And I had to discuss with him, if he was Jehovah's Witness, if he wanted to receive blood or not. And he did sign, but it was the whole consent and the whole discussion. He was crying the whole time, and it was very distressful for him. And these are just some of the things that, as someone else, you might not understand the person's religion, but it's something that really affects them. There are a few patients, Jehovah's Witness, that will accept, and there are some who will accept the blood fractions. It's just a discussion that needs to be had before. It needs to be clearly documented. They do have, they developed in 1988, a hospital information services. And pretty much what they have are these hospital liaison committees or persons that will have in-depth discussions with the patient and the medical team and determine what the patient is willing to accept versus what they're not willing to accept, and any other possibilities in terms of the procedure or any other options would be best suited to the patient in the medical illness and in terms of their blood, what they can receive. There is also this whole development of, if you Google it, bloodless surgery. There are centers that are offering this whole concept of bloodless surgery. And as you said before I started the presentation, that really it's principles that all surgeons should be practicing. And I'll go through a little bit more in detail about that. And as I said before, it should be clearly documented, the consent, and should be separate from the general consent to the procedure. Should be documented to discuss with the patient and the hospital liaison person exactly what the patient is accepting and not accepting, so that, if, for example, a general surgery procedure where the patient might be having maybe a mastectomy, the chance of needing blood is much less than if patients having cardiac surgery, but you can never tell what can happen during a procedure. So it needs to be clearly documented, even though the chance is 1% of them needing a blood transfusion or something going wrong. It needs to be clearly documented what the patient wants if anything were to happen. For us, the risk of needing a blood transfusion is much higher, and I'll go to the details about that shortly. But whether it's a minor procedure or not, it needs to be well documented, clearly discussed with the patient and their liaison person. And in addition, it should be a multidisciplinary approach, not just the surgeon and the patient, as well as an anesthetic team, as well as the practitioners, the hematological consultants, that everyone can offer the best option that's suited for the patient. And what is the concern with, say, Jehovah's Witness undergoing cardiac surgery? It's much different than other specialties for a number of reasons, and I'll go into it here. In terms of the transfusion rates, on average, it ranges widely, but on average, maybe about 50% of patients undergoing cardiac surgery will require some form of a transfusion, with the platelets, plasma, or red cells. And actually, a figure from the Society of Thoracic Surgeons, this is a US-based society, and when they looked in the 2014 data for patients undergoing coronary artery bypass grafting, the rate was at about 44%. There is quite a large volume versus a patient undergoing maybe orthopedic surgery or maybe general surgery. There's a much higher chance of needing transfusions with cardiac surgery. And what is it exactly about cardiac surgery? Certain factors associated with having cardiac surgery that puts you at a higher risk of needing a blood transfusion. And I'll try to explain some of them here. Is that when we go on to what we call cardiopulmonary bypass, so it's essentially when we have to open the heart and have to stop the heart, the rest of the body still needs needs blood. So in order to do that, to operate on the heart and to stop the heart, we have to put them on the bypass machine, or you might hear heart-lung machine, that essentially functions as a heart and the lung while we stop it to work on it. And it's essentially draining the blood from the body, passing it through some tubes into a pump that will oxygenate the blood and then clear it of any carbon dioxide, waste and whatnot, and then pump it back into the body. So it's tubes that go from the patient to a pump, to filters, to the oxygenator, to temperature probes to either warm or cool the blood, and then to additional tubes goes back to the patient. So usually what we do, because the heart is stopped, we try to lower the temperature to reduce the metabolic demand of the heart, and it helps to reduce the injury to the heart while we're on cardiopulmonary bypass. Now, for the longer time that we're on cardiopulmonary bypass, the more significant or severe the injury, and the patients tend to bleed more or need more blood products after. So just even, the nature of the procedure, some patients are coming for maybe a single valve procedure, which might not have much of an insult, versus a patient coming for coronary artery bypass plus 2 valves. Their bypass time will be much longer, and the insult to the patient will be much more significant. These are factors that have to be taken into place as well. In addition to the cardiopulmonary bypass, the tubing, we have to usually prime it with crystalloid, and that essentially, usually the volume can be about 1.5 to 2 liters, and that will dilute, because hemodilution decreases the coagulants in the patient's blood, decreases the hemoglobin and things like that. In addition, on the cardiopulmonary bypass, because we have to function as a heart, so we have to pump the heart back into the body, the bypass machine, and it's actually a pump that rolls. It's called a roller pump, and it can have mechanical destruction of your platelets, of your red cells. So there are a number of factors related to cardiac surgery that puts the patient at increased risk of needing a transfusion. In addition, a lot of the patients that are going for cardiac surgery are on antiplatelets. They might be anticoagulated before surgery. So again, this puts the patient at increased risk of needing a blood transfusion. In addition, we're doing a lot of vascular anastomosis. So for example, the aorta that comes directly from the left ventricle, it's the highest and largest artery in the body. So if we're putting stitches into that, we have to replace the ascending aorta for whatever reason, it's probably the most significant risk anastomosis in terms of bleeding. These are just some of the reasons why, a Jehovah's Witness having cardiac surgery is much more of a challenge, much more, needs more planning. And, in general, cardiac surgery patients tend to need more blood transfusions. So in terms of the management of patients, if done on an elective basis, we'll divide it into preoperative, intraoperative, and post-operative. In terms of preoperative management, one thing you can do, if the patient doesn't need to have the surgery, in terms of they can have a percutaneous procedure on the cardiologist that might be better suited versus having to have open heart surgery. And with the advancements that are happening, more and more surgeries that the cardiac surgeons will do, the cardiologist can actually do them endovascularly. And that limits the chance of bleeding. You don't have to avoid a whole sternotomy and all of that. So if there is a percutaneous option, that might be better suited for this subset of patients. And again, as I said before, it has to be a multidisciplinary approach, a discussion with the patient, surgeons, anesthetists, the cardiologist in terms of what's the best option for this particular patient. And again, as I said before, things are changing quite quickly in all specialties. You have off-pump coronary artery bypass grafting, which is done fairly common. It avoids the patient being put on the cardiopulmonary bypass. So you avoid all of those things that I listed before in terms of having to cool the patient, in terms of having destruction of your red cells on the pump, in terms of the hemodilution. That's avoiding when you offer the patient off-pump coronary artery bypass grafting. So that's an option if that, looking at the patient, is this a surgery that we can offer the patient that would be better suited for this subset of patients? Some surgeons, not all surgeons do off-pump coronary artery bypass grafting, but if the patient comes to you and someone else is better suited, it'll be in the best interest of the patient to probably have a surgeon that does off-pump coronary artery bypass grafting. As I said before, antiplatelets. Most of our patients tend to be on some form of antiplatelet. Either they've had a stent in the past, they're for coronary artery bypass grafting, and it's just given for prophylaxis to reduce the risk of them having a myocardial infarction while awaiting bypass surgery, for example. So we would at least want a more prolonged time versus other patients for the Jehovah's Witness patients. For patients who undergo cardiac catheterization, which for patients over 60 is practically almost every patient, and for patients who need coronary artery bypass, it would be all of those patients. They'd exposed to contrast. There's a risk of renal impairment, and renal impairment can affect the qualitative function of platelets. So you might want an increased time between these patients that have had their cardiac catheterization and the timing of the surgery. And then, based on their blood tests, there's a threshold that we can use to decide whether to give them iron and other supplementation erythropoietin. Here we use about 140 grams per liter. I've seen other centers use 12. So again, it's just looking at the patient, what are they willing to accept? Can we offer them anything that may be better suited for them? And is there anything medically that we can optimize? And also, there are other things that they can, some people look at if they're on any other medication. Sometimes they say garlic or other medication that can increase the risk of bleeding. Some people recommend stopping certain foods in the diet. In terms of intraoperative management, I'm just going to quickly list some things here, and I'll show some pictures after so you can better understand some of the things that I'm talking about. So in terms of intraoperative management, as I said before, most cases are done what we call the cardiopulmonary bypass machine, and it's where we have to drain the blood from the patient because we stop the heart, but other areas of the body still need the blood. So we have to take the blood out, put it through the bypass machine, and then return it to the patient. And when the tubing, as I said before, can take about maybe 1.5 liters to 2 liters of crystalloid because it's hemodilution. So what we can do is actually prime the tubing with the patient's blood at the time of surgery to reduce that dilution from the crystalloid in the tubing. In addition, we can try to use smaller tubing to reduce the hemodilution effect. And then we can also filtrate, ultrafiltration, reduce the crystalloid effect, and use a lot of diuretics while we're on the cardiopulmonary bypass, trying to concentrate their blood volume. And then we can use what we call like the cell salvage machine or pump suckers. One key thing in the Jehovah's Witness, as I said before, once it leaves the body, it has to be disposed of. So typical with the cell salvage machine, it's like a suction that we suction the blood when we're in surgery, and it's packaged into like a bag, like a red cell bag, and we can give it to the patient when they get to the intensive care unit, but it's separated from their circulation. Usually that's what we do. But when the patient is a Jehovah's Witness, the blood has to be in continuous circulation. If you break the circulation, most won't accept it. Some do, and again, this is something that will be clarified in the preoperative period, in the informed consent, if this is something that they'll accept or not, but most tend not to accept once the continuity is broken, and that blood has to be discarded. So that if you're going to use a cell salvage machine, it has to be in continuous circulation with the patient. And in terms of surgical technique as well, meticulous hemostasis, which should be across the board for all patients. Some things that we can look at in terms of limited use of gauze. The more gauze we use, even though what we do is we squeeze the gauze and we use the cell saver to suction any blood that's in the gauze. No matter how much you squeeze, you still won't be able to get every drop out of it. So if you use less amount of gauze, you'll be using less volume, less red cells, essentially. So, and then just your technique in terms of, just making sure that nothing is bleeding, addressing hemostasis, as you open and as you close. There is the use of topical hemostatic agents, bone wax. I'll show a picture of that after. And then synthetic sealants and oxidized cellulose hemostats, which the brand name you might hear is Surgicel, which we use often. Or for the sealant, we might hear about Flow Seal. And then we can use blood derivatives. But again, this one should be clarified preoperatively because there's some Jehovah's Witnesses that won't accept and there's some that will. This one is, again, as I said before, in the gray area. So like topical fibrinogen or thrombin. And there is use of tranexamic acid. Different centers have different protocols, and then again, sometimes it's tailored to the patient rather than a set standard for all patients. Each situation is different, each surgery is different, different things can happen in the surgery. So it has to be tailored to that particular patient. So as I mentioned before, this is just a picture of the bypass machine here. I don't know if you can see my arrow on the bypass machine. So these are actually the pumps here and the tubing here. So these are the tubings coming from the patient. So one is arterial and one is the venous. So one is taking blood from the patient, putting it through all these different things, the temperature probe, oxygenator, and then this is a roller pump. There's a pump that's actually squeezing the tube to pump it back to the patient. And it's always in continuous circulation with the patient. It never breaks. And this is a reservoir that keeps the blood, but it's in continuous circulation. And then each pump is for something different. So this one is for to return the blood to the patient. This one here might be for what we call suction. So it's always in the system, okay? And then here's just a brief, so we'll put the cannula here. So this is the aortic cannula. This is to return blood to the patient. We normally have a clamp here called a cross clamp, and then blood goes here to perfuse the rest of the body. And then we drain blood from the right atrium or IVC. And from here, the blood goes here to the bypass machine. So everything over this side here is a bypass machine, which will be represented by this. Okay? And it's, as I said before, in continuous circulation. So these are just some pictures of some of the things I said before. I'm not sure if anyone was familiar with it, but so this is a picture of a sternotomy here. So this will be the patient's head here. This is a picture taken from the side of the patient, and the patient's feet would be down here. So this is actually the sternum right here, and this is the skin, and this is the subcutaneous tissue with fat cells, and then here is the sternum, what we call the breastbone. And usually the marrow bleeds quite a bit. So once you open the chest here, what we can use is this is a picture of what we call bone wax. We use this and rub it into the marrow area to help to stop the marrow from bleeding. It's one of the things that, to help to reduce the chance of blood loss from here. In addition, I spoke about Flow Seal, which is a topical hemostatic agent, thrombin. So it comes in like, you have to mix it and prepare it, and then it goes into a syringe. So this is a patient who's had their part of their aorta replaced here. As I said before, the aorta is the largest arterial vessel and has the highest blood pressure in the entire body. So imagine changing this and stitching it on here, and it's being exposed to very high pressures. You know, when you put your needle in and stitch it in, you can have bleeding from the suture lines and things like that. So it can be quite difficult to get hemostasis. And sometimes they've developed these topical hemostatic agents here, and you can see the syringe here, where you can apply it to your anastomosis to help to reduce the chance of bleeding. So these are things that you could prophylactically put, you know, if you know that you're going to have a patient that's Jehovah's Witness, to help to reduce the chance of bleeding there. And it's just part of the, you know, good surgical technique. And this one here is what we call oxidized cellulose, and this is what it looks like. It's called Surgicel, is the brand name. And if you have anywhere that's bleeding, you can just take a piece of the Surgicel and put it there, and it acts like a mesh to help to entrap all the cells involved in hemostasis. And it's just a picture to just show some of the adjuncts that we can use to help to achieve, to secure hemostasis. In terms of the post-operative management, you want to avoid hypertension. For example, to the patient who might have had replacement of their aorta, you know, if the higher the blood pressure goes, the higher the pressure is that your vascular anastomosis is being exposed to, the increased risk that you're going to have bleeding from your suture lines and things like that. So you want to avoid very high blood pressures after surgery. You want to try and keep them at a normal temperature. Hypothermia affects coagulation. So the colder the patient is, it increases the chance of them bleeding. You want to maximize oxygen delivery. And as we saw in the case that I discussed first, the patient was ventilated for a longer period of time, high FiO2, and was on inotropic support to just maximize oxygen delivery. You want to reduce bloodletting. You might want to decrease the frequency of the blood sampling and what you're taking, the possibility of using pediatric tubes as well, and supplementation with iron, folic acid, erythropoietin as the case may need. As you saw from the patient I discussed, he did fine. He wouldn't have needed the ventilation or the extra inotropic support and reduced bloodletting if he had had the incident where he had bleeding. he did quite well with surgery, but unfortunately there was a bleeding episode and he arrested and had to do extra maneuvers. Again, each situation is tailored to the patient that you have. So in summary, MDT approach, the patient meeting with their hospital liaison in person, the surgeon, anesthetic team, practitioners, the hematologists, the cardiologist. Is there anything else that we could offer the patient that may be better suited than having surgery? Cardiac surgery is associated with an increased risk of needing blood transfusion. Clearly documented consent. Apart from the usual normal consent, there should be something documented about clearly what the patient will accept. And in addition, if things change, the patient needs to be aware that, he may get in a situation where he or she may die if they do not receive blood. That needs to be documented what the patient wants to do. Emotions can get involved and patients might change their minds. So it just needs to be clearly documented what the patient wants in the event that things change, the situation changes. And again, just to remember that we have the pre-operative management, intraoperative, and the post-operative management. And that's pretty much. And I want to thank you for giving me the opportunity to present, and I hope it was beneficial.